Most important, as far as the Tanzanian healthcare system is concerned, is investment into the primary healthcare. Kwa sababu Tanzania, 98% of Tanzanians, they start contacting primary healthcare before they are sent into our healthcare system. For your primary healthcare is a strategic level where we need to have some investment. Most of the discussions here today, we just spoke about the health facilities. We forgot about communities. Hauwezi kufanikiwa without proper investment in communities. As diseases begins in communities, they end in the communities. We need to bridge the gap between we as healthcare providers from the facility and those who are providing services at the community. Hapo ndio tutakuwa na continuum of care. And we also need to make sure that in the area of service delivery, we do not just talk about the patient safety, we should also talk about the healthcare workers' safety. Vyote viwili vinatakiwa viende kwa pamoja, not paying much attention to only the patient and leaving the healthcare worker peke yake. So in this system building blocks, these are the ones that were actually formulated by WHO. Lakini sisi, in the group of healthcare system, the African group, we challenged that. Kwamba we cannot provide healthcare services kwa kuwa na 6 building blocks alone. So outside those 6 building blocks, those are the drivers also of the healthcare system. The commercial determinants of health. We have now the sugary drinks. The issue to do with salt intake. They have got a lot of bearing into our health system. Political determinants. For us to succeed, Nimemwona my sister Mary presented the issue to do with research, the research appetite. We need politicians to drive the agenda. From policy formulation, mpaka sikufanikiwa. You need a buy-in from the politicians. Kuna issue of global health initiatives. These are the ones who drives all these agendas which we have. And one of the challenges most of the resource-limited countries have been experiencing are the vertical program. TB, malaria, HIV. Why the system doesn't work that way? The system wants integration for it to perform up to the expectation. So here, ni muhimu sana. And then last is the social determinants of health. So we did present our position paper to WHO, trying to challenge those 6 building blocks, and now we have started the conversation. So soon there will be coming out the revised building blocks. And likely in our last year's published book, which is on the primary healthcare in Tanzania through a health system lens, a history of struggle for universal coverage, we have also made sure that we have a revised version of these 6 building blocks. So I'll donate this book to the president of March so that it can go to the library. So we have another block, medicine and technology. Much of our discussions here, we didn't talk about AI. Issues to do with machine learning, robotics. This is how the medicine goes. You know, over time, medicine evolves. 60 years ago, no one could discuss about AI, machine learning, robotics. But now we have a lot of advances in healthcare delivery. We should be able to discuss about that. So as a strong supply chain management for health commodities, and I was very happy to hear my brother Mavere talking the issue of local manufacturing capacity, because we, in sub-Saharan Africa, we import up to 95% of medicines and vaccines kutoka nje. And then that our capacity is still low. We need to make sure that we invest in that area wisely. Oh, doesn't move? Sorry. slide. Next slide, please. So I'll quickly take you through the definition of quality. I know kila mtu amekusikia quality, but today's definition is one of the simplest one, which is quality. This is the degree to which health services for individuals and communities increase the likelihood of desired health outcome. We have had a number of versions of quality. I would say when I was looking for the definition, I gotten around 1,500 results, meaning that there have been definition, redefinition, and that shows how important the topic is. But in 1966, there was one scientist who simplified this definition by coming with 3 dimensions: structure, processes, and the outcome. Kwamba quality is packaged into 3 dimensions, and that was Donabedian. Kwamba in the structure, we invest into human resource for health, we invest into buildings, we invest into vehicles, the ambulances, and to name few. Whereas in the processes where you have the SOPs, una vitu mbalimbali viko hapo kwenye processes, how do you conduct your procedures and other things. Whereas kwenye outcome is where unapata feedback from the patients whom you have treated. Oftentimes kwenye quality zetu, we focus with the structure and the process. Ukisha kwa discharged, utajijua mwenyewe. And that is, ukisha fail to address the last dimension of outcome, hujafanikishwa quality. And I was very intrigued and I was very happy to hear that Jakaya Mrisho Kikwete Cardiac Institute wana gadget saizi wakishamdischarge mtu kwenda nyumbani, ina report kila siku reading ya blood pressure yake, na pale unapoona kwamba it doesn't point kwenye direction, wanamuita au wanamfuata mtu. And that is total quality, and this is what we are trying to advocate. But the most important, when we speak about quality, we should touch the entire care framework. We need quality health promotion. Health promotion materials should be up to the standards which is needed. We need prevention and protection. We need quality curative services, rehabilitative services, and palliative services. So, here ni kwenye upande wa clinical. But with science evolution, now we are learning kumtibu mtu peke yake haitoshi. You need also to focus on issues that are non-health related. For instance, gesture of a clinician or a nurse, communication, privacy, confidentiality, basic amenities, all these contribute to quality. The waiting time. Una CT scan na kila kitu na wataalamu pale, it takes me 5 hours. Quality talisharibika. So we conducted the research and published. And I'm sorry, maybe this is also another cross-sectional study. So kuangalia health system responsiveness. In Tanzania, kwenye primary health care, health system responsiveness is only 60%. Meaning watu 40% wanakuwa satisfied. Now unavyo interact with sisi tunavyokuwa vituoni, namna unavyokutana mazingira yanayozunguka pale. One of the daktari said hali ya theater haijakaa vizuri. So you can have all the equipment needed, but if you do not have good facilities, then you're in trouble. Lakini, for us to deliver quality services, what do we need? We need a strong partnership, we need collaborations, and we need to be supported by health diplomacy, both at the regional and at the global levels. So why do we need now regional and sub-regional health bodies? Kwa nini tunahitaji EXA, health community? Kwa nini tunahitaji WHO? Why do we need Africa CDC? Why do we need West Africa Health Organization? Kwa sababu diseases respects no borders, lakini challenges ambazo tunazipata, they always cross borders. And I'm very much happy to see we have colleagues from Kenya and also we have colleagues from Zambia. Lakini, peer regional bodies are essential for addressing the unique and shared challenge in that particular region. EXA is the only pan-Africanist intergovernmental body that is dedicated exclusively to strengthen health systems across East, Central, and Southern Africa. So, EXA, kwanza kikubwa, EXA ni ya kwenu. It is your organization. Wote mliopo hapa ndani, whether you're coming from Zambia, whether you're coming from Kenya, this is your organization. And EXA, as I said earlier, this is a regional intergovernmental, but it is also a diplomatic organization. Na hii was established 51 years ago under the auspice of Commonwealth. So Commonwealth Secretariat ndio ambayo gave birth to EXA 51 years ago. As I said, as we celebrate 60 years of MAT existence, we also celebrate 51 years of EXA health community existence. Currently, we are comprised of 9 member states. Those member states ambazo kwenye blue ndio EXA. Lakini, we have projects in 30 African countries. How do we operate? In those countries which are non-member states, we sign MOU, we work together with that particular project. While these are the countries, and I'm happy watu wote wapo ndani ya EXA. So how is our governance structure look like? So we assume the pyramid shape. At the base of the pyramid is the EXA Health Community Secretariat, ambapo yupo DG. Then we have the Program Expert Committee. You'll be receiving number of invitations to come and make contributions to those committee. Then we have the Directors Joint Consultative Committee, ambayo hiyo ndio hapo CMOs or other countries they call the Director Generals. But also we have the Advisory Committee, which is comprised of permanent secretaries or principal secretaries in some other countries. The supreme body for EXA is Mkutano wa Mawaziri, Health Ministers Conference. Those are the ones who are mandated to hiring and firing. So to your right-hand side, we have the Director General with 3 directors, 1 Director of Finance, Director of Operations and Institutional Development, after a Director Peer of Programs. Chini yake, we have 4 managers ambao wanaongoza clusters. Cluster of family health and infectious disease. We have another cluster for non-communicable diseases, food system and security and nutrition. And we have health system and capacity development. And here is where the colleges of health sciences are seated. Mwishoni kabisa tuna knowledge management. Alafu monitoring and evaluation is where the research ipo pale. So we are implementing 10 years strategic plan and with 9 strategic objectives. Luckily, this year's theme of our Congress ni moja ya strategic objective. That's why I was very happy when I was asked to deliver the keynote. So these are our areas of work. There are 8. They span from health promotion to protection, prevention, curative services, rehabilitative, as well as palliative care. Those are 8 areas of work. We have a number of projects here. As you may recall from the map which I just displayed, we exist in 30 countries. We have projects with Global Fund, ambayo inaangalia masuala ya regional laboratory strengthening. We have integrated laboratory strengthening systems, but also we have TB in the mining sector. Lakini pia tuna mradi mkubwa under the World Bank, ambao wenyewe ni kwenye swala la pandemic preparedness and response. It's where also we focus on antimicrobial resistance. We also deal with the cross-border surveillance and all issues around the health security. We have a number of partners from universities, research institutions, philanthropies. Na pia we have a very strong partner with our parent organization, that is Commonwealth. So when it comes to the human resource, swala la quality, it requires a very good investment kwenye human resource for health. And EXA has 11 colleges, and we call these colleges without wall, as people attend training while they're in their duty station. You need not to travel na kuondoka. Ndio maana our colleges, retention rate is above 95%. Now, so far, tuna graduates zaidi ya 1,800. Tuna hospitals karibia 277 ambazo zimekuwa accredited to provide that training. Lakini tuna trainers karibia 160, na retention kama nilivyosema in a very high retention rate. And to your right hand side, tutaziona pale tuna college anesthesia. And one of the questions that was asked here, upungufu anesthesia. We need to invest into that. Ili tuweze kupata watu wa usingizi na ganzi ambao ni wa kutosha. Kuna college now deal na mambo ya public health ambayo ni mpya kabisa. We have college ambayo ina deal na masuala OBGYN. Those to name few, but we have in total 11 colleges. So I'll just cite one example. That is a college ambayo inahusika na masuala ya surgery, the College of Surgeons. I started way back in 1950, lakini ilianza kama Association of Surgeons ya East Africa, but it evolved over time up until 1999, ambapo ndio ikawa ni COSEXA, ambayo ndio college sasa ya East, Central and Southern Africa. It has done a lot in terms of training the specialists, na pia tunaendelea kuboresha with time so that we get the best of the best. And most of the regions, they have come to EXA to learn on how to organize this type of training, where one is attending akiwa kwenye kituo chake cha kufanyia kazi, lakini at the same time anakuwa na uwezo kufikia ujuzi ule unaotakiwa. So what are the future plans with regard to EXA? So far tuna uwanja ambao ni 30 acres na Ngaramtoni. So we are planning to make ule uwanja na kudevelop to be the center of excellency Sasa the centers of excellence that we envision to have is research and innovation. There were a good discussion here on research and innovation. And I think this is going to be a solution to a number of challenges that we have in the region. Recently, nilikuwa nasikia na nilikuwa naongea na colleagues who are specialists. Wakasema kigezo cha kufanya research kiondolewe kwenye kupandishwa vyeo. Sasa nikasema hii hatari. Sasa ukisha ondoa utakuwa unashindana na nani? Kwa sababu sasa hizi the more tunavyoishi mipaka ya nchi inazidi kufa, dunia inakuwa ndogo. People move from one place to the other. So if you remove research, and we said no, we need now to find a solution. Why is it that watu wanasema hatutaki research? Hawataki evidence. Sasa mtu akikwambia hataki evidence kwenye ulimwengu wa sasa, you need to take it very seriously. So we thought we needed to have a center of excellency for research and innovation, lakini pia nyingine ya One Health. Tumeona, and I had a privilege to serve as a chief of operations kwa outbreak mbili. In 2023, ya Marburg, Kagera, na ya mwaka huu ya Marburg. But I also partly served kama chief of operation ya Mpox. Ndugu zangu, we need to invest into One Health. Most of these diseases, they are zoonotic diseases, and with movement of people from one place to the other. For instance, Marburg, ambayo sisi mwaka huu tulikuwa nayo as an outbreak here in Tanzania, it was a case last year in Rwanda. So we need to have that one. But public health emergency as a center of excellency, now issues to do with reproductive, maternal, newborn, adolescent, and child health. These are areas also we need to invest on. You know, there's variation in terms of maternal mortalities in the countries, which are the member states under Aicc. Tanzania in 104 per 1,000 live births. You go to Kenya, it's about 500. You go to some other countries like Mauritius, so we need to have a center of excellence where people they will be meeting. But we shall also have a business center in the hotels, in the recreation area. Sababu swala la well-being, it is as important as the lifeline. You cannot just deal with health and forgetting self-care and forgetting about the well-being. We need to invest in the well-being as well. Kwa sababu hiyo ni moja ya forgotten areas, and our well-being index in the region is still down there, so we need to uplift it. So for those who are interested, that's the area. And the three last bullets ni kikubwa for financial sustainability to be able to run Aicc. Lakini we need more colleges. And let me take this opportunity kuwakaribisha, because this is, I'm happy we have colleagues from Kenya, Zambia. Hii ni low-hanging fruit. We need college of mental health. I was discussing with Mary. Prevalence, yeah, step survey, ni 8%. And sub-Saharan Africa, mental health among youth and adolescents in Atisha, but access to mental health services is less than 10%, meaning we need to invest that. And I was discussing to team chama cha maswala mental health Tanzania. Wakasema wataalamu wa afya akili ya watoto na vijana ni wawili Tanzania in the population of 70 million. Then I had to ask in Eswatini, they do not have one. Mauritius, they do not have one. Malawi, they have one. Zambia, they have one. Ambaye na dealing na adolescent. Our population in Aicc region, youth ni 65%. And our entire population in Aicc region ni 270. So we really need, katika watu 270, 65% are youth. Those who are below 64 years of age. So we need to invest in that. Lakini there's another issue, primary health care and community health. We need a college on that. Leadership and health diplomacy. You cannot deliver quality bila kuwa na quality leaders. Never. Kwa sababu unaenda na proposal yako ya research anakuambia no. Unaenda na evidence anakuambia no. You need to invest on quality leaders. So we need another college for that. And we are inviting different stakeholders. Na nyingi tunapenda zitokee kutoka kwenu when you bring them here. Tunahitaji masuala ya kuongelea medical tourism. We have learned from Jakaya Mrisho Kikwete Cardiac Institute, number of countries bringing in people. Tuna Kenyatta Hospital in Kenya. Tuna hospitali pale Lusaka. All of them attract wagonjwa kwenye discipline fulani. But we need to have a very good regional strategy to make sure that whatever we are doing here is fine. We went to Burkina Faso. Actually, they deployed people to come to Tanzania to learn maswala cardiac surgery. Apart from Comoros, Zambia, and we have colleagues who went to Uganda to start a couple of things. So as I told you now, these borders, zabakia ko imaginary. People are moving from one place to the other. So you need to build the competence that you can compete with others. So soon we'll start providing scholarship opportunity for those colleges. We'll have those opportunities. Lakini pia, we want to invest in youth. All countries that have succeeded, they have invested in youth. So that most of youth whom I interact with, wanakuwa wanapata changamoto, even the career advancement, career progression, niingie wapi, nifanye nini. So we want to invest. And the EXA will start that soon. So we shall put tangazo namna kuweza kusaidia youth. Because they are 65%. If they are 65% and then you do not prepare them, what will happen in the next 25 years? Itakuwa ni changamoto. Then partnership and collaboration. We invite all the medical associations from Uganda, from Kenya, tunataka train MOU. But you come with an issue, wenyewe mnataka tushirikiane wapi? Soon we shall be starting the surgical and medical camps kwenye member states. Madaktari watatoka hapa, hawatatoka kote, watatoka hapa, watatoka Kenya, watatoka Malawi. So we need to have sort of MOU or teaming up agreement. You want to write or to apply for a grant, unakuja na EXA mnakaa pale. We write a grant together. Most of these associations, they do not have adequate resources to run. We can be of help in assisting you in that through our partnership and collaborations. But also, tuna opportunities for consultancies. Yani consultancies ziko nyingi. So whenever we put down any tangazo na nini, come forward, apply. Because those are the international. Yoyote they apply from anywhere. You just do it. But also you can bring your unsolicited proposals. Kama sisi tumeangalia in this region, we think we need to do 1, 2, 3. We discuss and also provide you resources. But we also want to establish an internship program. Now you focus for youth. We need to expose them with regional health politics, global health politics. They need to know that you cannot compete with people from West Africa who have been exposed before kwa kutumia a very good system. You need to be exposed as well. But in publishing. So publishing, that is going to be one of areas that we want to support member states and associations. So these are our partners. We have a number of them. And many have also expressed interest to work with EXA. We welcome, and I believe after concluding my presentation, still I'll have some from this audience. So karibuni, we are working very close with East Africa Community, WHO, with my brother Professor Janabi. And also we have Jean Kassea from the Africa CDC. This is how we work. The world we are living in, you need partnership and collaboration. We have a call for abstract team. From 5th to 8th, 7th of August, we will be in Port Louis. Tunataka mlete abstract na tume extend deadline. Deadline itaenda mpaka tarehe 30 of this month. Bring your abstract. Kule mtakutana na gurus in different areas. We will have talks in primary health care, associations and other things. We want that. Lakini tusahau leo ni Sickle Cell Day, World Sickle Cell Day. Sisi tuna promote killer commemoration at the regional and global level. Kwa sababu otherwise kuna watu watakuwa marginalized. We should be the voice ya watu wengine. And we want even these medical associations to do the same. So in conclusion, as I said, we are both technical and diplomatic. We drive regional agenda, but we believe in science. And I cannot tell you, yani hakuna kitu tunachoamini katika science. We want science. We want solidarity. So now tutakuwa tunafanya kazi na all the medical associations. I will reach out to Kenya. They should be able, medical associations should be the drivers of policy na vitu mbalimbali. They should be able to invite EXA, Zambia as well. They should be able to do so. When we have the regional solidarity, vitu vitabadilika haraka. But we cannot continue working in silos or being fragmented. We want to be able to achieve what we want to do. We need to bridge the gap between research and the industry, bridge the gap between the clinical and the public and global health. Ndio dunia inavyotutaka. I beg to submit. Asante.
Thank you so much, Dr. Ntuli. Please don't leave the podium. We're going to take a few questions. If there are any, I believe there are going to be a lot of burning questions. So questions, please. First come, first serve. Dr. Elisha, karibu. Any other question, please raise your hand to kulete mic.
Asante sana, Dr. Ntuli, for a comprehensive presentation. Na maswali mawili. Moja, you talked about publications. I declare interest, I chair NATREC. And the problem that we are getting with publication, because we have a policy now in our country for specialists to be promoted should have at least a single publication within 3 years. And the minutes here probably tomorrow we'll discuss on that. But we have very few journals that accept our publications. So how can EXA bridge that gap so that we have, we have the so-called international journals and local journals? Why ours are local? And how can EXA help us in that? Number two, so we have collegiate trainings through EXA College, COSEXA, EXACOP, EXACOG, and the like. The problem that we are sometimes getting, that you might find within hospital, let's say at Mwimbili or KSMC, there is an already ongoing MED program, let's say for obs and gyne. At the same time, within those hospitals, you find there is an initiation of collegiate training by EXA programs. And the problem that's happening is that when the TCU and the MCTs are coming, they'll tell you, you guys are competing for resources. You compete for patients, you compete for theater space, number of patients. So competition for the resources. That, jeopardize the training. Because I understand initially the program was MED program and college training should run, should complement each other to reduce the shortage of resources. Sasa, within those hospitals, unakuta kuna hiyo tatizo, which jeopardize the quality of training. So how can we solve this and make sure that we capacitate our RRH probably to take up the collegiate training, ili kuweza kusaidia pia some of our there, lakini pia the quality of the training.
Asante sana kwa maswali yako mazuri. Tuwape nafasi na watu wengine.
Asante sana.
Nakushukuru. Leo umekuwa very brief. And I'm very happy.
Thank you. Another question, one question please, and straight to the point. Okay.
All right, thank you. My name is Isaac Maro. Thank you for the very nice presentation. And once again, congratulations for the position that you just recently been appointed. We are actually seeing changes now. My question is going straight to, we know that health promotion is one of the integral part of health and the progress as far as health is concerned. EXA has been in play since 1974, as you've been saying. And for most of us, these are the first time we are hearing about EXA. Are we, or are you, I'm speaking as if I'm in EXA. What are the plans to make sure that people that are not in this room know about EXA? And how can people, get access to all these opportunities, not only in Tanzania, but in the rest of the member countries? Thank you.
Thank you so much. One last question.
Asante sana Dr. Ntuli Kapologwe. Nafurahi kukuona umekuja na reach out kwenye mkutano kama huu. These are commendable initiatives za kuifanya EXA iweze kufanya kazi na vyama vya kitaaluma. Hata hivyo, ninaona tumejikita sana kwenye kuzalisha professionals ambao bado tunawahitaji katika taifa hili. Lakini tunafahamu ya kwamba ili matokeo ya kile mnachokifanya yatokee, lazima tuzalishe viongozi bora, kuanzia kwenye afya ya msingi kwenye zahanati mpaka tufike huku juu kwenye hospitali za rufaa. Sasa je, EXA ina mpango gani, ama kwenye matarajio yako unadhani ni wakati sahihi sasa wa kuanzisha EXA leadership au kushirikiana na wengine ili kumsaidia medical officer in charge aweze kuwa na uwezo wa kiuongozi na kuexecute majukumu yote ya kisera yanayotungwa na sera za wizara ambazo ziko kwenye chini ya EXA? Asante.
Asante, please go ahead.
Asante. So hiyo la mwisho ndio tumesema tunaanzisha leadership and health diplomacy program, lakini itakuwa na wale ambao mpo kwenye different levels za uongozi and na nyingine kwa ajili ya youth, kwa sababu sisi we want to be a pro youth organization. That's why we are going to establish even a youth wing. Tutakuwa na youth wing kwa ajili ya kuaddress issues, kwa mfano masuala ya sexual and reproductive health and rights kwa youth, mental health kwa youth, na hata masuala ya one health kwa youth. Kwa hiyo tutakuwepo na hiyo kwa ajili ya watu wote, including the desk ya masuala ya international health. I did a quick assessment and I found only Kenya, they have a well-established desk for international health and health diplomacy. Tanzania wapi haipo. Sasa you cannot go into negotiations at the regional global level without having a well-coordinated and organized desk. And swear vitu vinaenda vibaya. People meet in Geneva and they'll be meeting, wanaangaliana usoni, hivi tumekuja kufanya nini? Magorofa hapa mazuri nini? Wanarudi nyumbani, hamna kitu alichoweza kurudi nacho pale. So we are going to make sure that we make your desk inakuwa imekaa vizuri. Lakini there's another thing ambacho muulizwa na Isaac kwenye swala ya visibility. If you go through our strategy kwenye page 15, you find tumeongelea swala ya visibility of EXA. Na ndio maana saizi hata na encourage watu waliopo humu ndani, tumetoa tangazo, tunataka communication specialist. Deadline tarehe 21. Ila tumesha tengeneza communication strategy ya 5 years. Lakini pia tunataka tutumie mainstream na social media platform kuweza kufikisha mambo mbalimbali. Ila kuna kozi nyingine ambayo tulikuwa tumeongea na Tanzania Medical Media Council Tanzania Media Council kuanzisha kitu kinaitwa public health communication. Unajua, it's not easy to communicate health issues. Wanaangalia kwa TV unasema mwenzangu amejitahidi hapa. Yani it's not easy. So you need to have a college ambayo inatengeneza watu to communicate vitu alivyokuwa anaongea Mary hapa, alivyokuwa anaongea Mavere na other former presenters kwa lugha laini ya watu kuelewa. Kwa hiyo ni eneo ambalo tunaliona ni lazima tuweke. Sasa kuna swala aliuliza Dr. Osati kwenye research, as I told you, and I also told Mary Maige, kwamba specialists wanakimbia research, hawataki, na wanasema hicho kigezo kiondolewe. Angalia nchi nyingine zote duniani, hicho kigezo ni cha muhimu kutengeneza quality specialist. Mimi nilikuwa mjumbe wa body wa NIMRI, so we said we must have a strategy. Sasa wenyewe kina Mary wanafanya strategy at a national level, but at a regional level we are coming with a regional research agenda. Lakini how do we capacitate member states watu waweze kufanya research, na kwamba research sio ngumu. Sababu sasa unajua ile degree ya kwanza medical school ndio inayotufanya watu waanze kuogopa kuchukua research, and then later only to kuona kitu cha kawaida kabisa mtoto anaanza kufanya. Kwa this is an area we need to invest, and it's not only in Tanzania. Uenda kuongea na specialists wa Malawi wanaongea hivyo. Okay, yani inafanana. So tumeona this is an opportunity kuleta regional approach, tuwe na agenda na namna ambavyo tuta capacitate people. Kwa mtu atanayekimbia away from research, huyo hapendi evidence. Yani anakuwa ni mtu wa hisia tu. Hapa nadhani hapa kuna hataki kutumia science. Kwa hiyo mtu akiwa anakimbia science au usitegemee mtakuwa na quality healthcare service. Lakini kulikuwa na swala la competition. So one of the challenges which I got when I arrived in the office, waliniambia hiyo kama kuna nani. So I'll be calling meetings na number of colleges to address some of the challenges, including recognition. You go to Uganda and Zambia, you find they recognize cause moja. Tanzania naikataa. Au Tanzania wana recognize, you go to Malawi. So I want to have a good engagement na vyombo kama TCU, MCT to discuss kwamba world ina move hivi. Ndio maana tuna Royal College ya London, Edinburgh, dunia America, hakuna dunia, yani dunia ndio hivyo. Ni sasa na saizi ujifanye unakimbia hii. Yani unatafuta matatizo mwenyewe kwa sababu utajikuta uko isolated. Kwa sababu dunia inakwenda hivyo, unajifanya unakataa baadhi ya vitu. So mimi I should thank all the people who ask questions. Narudia kusema EXA is your organization. Is 2 kilometers away from here. Ndio ofisi zetu ziko pale. Unaenda pale, unakuja. Na mimi ni open door policy. Ukitaka kukutana na mimi uje saa 1:30. Hiyo uhitaji appointment. Nimepandisha kidogo kuliko nilikuwa nafanya kazi kwingine kwa saa 12:30. Sasa hizi saa 1:30. Unakuja bila appointment. We talk mpaka saa 2:30. Namna gani tunashirikiana ili kufanya organization iwe na contribution. Kwa mfano mambo ya NHIF, universal coverage. Tuna watu tunafanya kazi vizuri wa York University Uingereza kwenye funds la ONSE. One of the projects when healthcare financing. Watu wakitaka msaada namna gani tunaweza kusaidia eneo hilo, we'll be happy to support, kwa sababu tuna timu ya watu ambao wanajua masuala ya healthcare financing. So hizo ni kidogo tu, lakini we will get to discuss mkija mkitembelea hapo ofisini, ambapo uhitaji gari ili kumuunga mkono Dr. Meige kwenye mapambano zile NCD, kwa sababu ni 2 kilometers kutokea hapa. Kwa hiyo unatembea tu, unakuja hapa, we sit, we talk, na tunamaliza. Namalizia sasa, hii kitabu ni sawa nampa Mgisha kwa ajili ya library ya Mati. So Mgisha, karibu sana kupokea kitabu. Hichi kitabu kimeandikwa na authors 50 wa Tanzania kutoka kwenye research institution, wengine wametoka kwenye training institution, policy makers na implementers. It is dated back 1800, kuanzia 1800 hospitali yetu ya kwanza ilikuwa wapi na nini. Hivyo evolve mpaka kufikia mwaka 2024. Kwa hiyo nadhani kumbukumbu na mati mwaka uliozaliwa iko ndani. Nadhani itakuwa ni muhimu sana kwa Mr. President kuwa nayo.
Asante sana Mr. Ntuli. Makofi hayatoshi kwa nondo alizotoa hapa. Makofi jamani. Thank you so much Dr. Ntuli for that speech. Now we are going to hear from Dr. Arnold Koresha, who is from Tanzania Health Summit. Is going to speak about is your facility SafeCare ready? Discover quality standards that sets you apart. Karibu Arnold.
Good afternoon. My name is Dr. Arnold Koresha, and I'm working with Tanzania Health Summit as the SafeCare Program Coordinator. I'm very happy to be here in front of you, and I'm so much to the Medical Association of Tanzania for giving us this chance, aligning with the theme about quality. So, I want a bit to share of my journey. This was around 2002. Nilikuwa kijana mdogo. And I happened like many other kids, shilingi 10. So Gen Z sasa hivi nafikiri mnaweza mkajua shilingi 10 sasa hivi ni kama shilingi 500. And by the time facility yetu ilikuwa ni umbali mrefu sana. I remember the dress my mom had worn kunibeba mgongoni, na mpaka tunafika pale haikuwezekana kuweza kutibiwa katika health center. Ikabidi mzee wangu alipie defender ya police na kuweza kunipeleka mpaka 60 kilometers away from there kuweza kupata huduma, na nikafanikiwa. And you know what, 23 years after, that facility that tried to save my life, now as the worker. So I'm so much committed. I got the zeal to work in this system strengthening, especially in quality. Sasa hivi kwenye wilaya yangu kuna district hospital, but again kuna regional referral hospital. So I'm very happy. I know Tanzania has been so much working to ensure that there is quality, accessibility of care.
Koresha, naomba utaje wilaya.
Natokea wilaya ya Chato.
Asante sana.
Yes. You know why I talk about this zeal that I have in myself? Because quality actually matters, you know. Quality matters because now a lot of people have died because of poor quality of care. Around 5.7 to 4 million, as per WHO data, died due to poor quality. And you know what? Only 40% of those people is about non-utilization, but 60% is poor quality. So we have something to work on. But again, trust. When your facility gives high quality services, people will try to recommend, will give trust to your facility. So we need to invest in this thing, and we have all reasons to do that. But again, costs, productivity, increase of cost in productivity is high when you have poor quality of care. Now, I'm here speaking on behalf of SafeCare. That has proven so much impact in different countries. One of them being Kenya, Nigeria, even in Tanzania. Facilities like St. Joseph have proven a lot of impact because of enrolling themselves in this assessment program. Even Mount Meru, a round of applause again to Mount Meru, because they are so much committed, they have employed SafeCare, which has proven them to give them in of maintaining quality. So how does SafeCare being known. So SafeCare is an international accredited framework. It is accredited and certified by the International Society of Quality in Healthcare, and it is distributed globally in 27 plus countries, enrolling about 9,448 facilities. So it is a stepwise certification, stepwise process of quality assessment and quality growth from level 1 to level 5 of quality. And this gets support from the local, like us Tanzania Summit supporters, but also it's globally known, and there's a global support at the SafeCare, the international program. So you need to enroll in this program so that you get a demonstration of quality. Now we are going to, our country is going to be home for competitions like AFCON, CHAN, and so we are also trying to give our force of ourselves into tourism, medical tourism. So you need to be known internationally that you have highest quality provision in your facility. So with this SafeCare, you'll be internationally recognized, but also you increase patients' trust because they know that this is an international certification, it's an international quality level, and will attract more patients, and so is revenue. But also operational, we need to make it sustainability. This SafeCare program employs a holistic approach in non-clinical organizational risk management. So when you put things in SOP guidelines, you will strengthen the system, and operational costs, operational functions will be made easy. But we have been talking about data. A lot of people here have been talking about data to make sure that we have data in quality. And for us, we have a digital platform that ensures the facility leader has got this data of closing the gaps in quality that are found in his or her facility. So now how does it work? There's assessors from our organization who come and assess your facility. After that, we identify the gaps. After that, we offer the quality improvement plan, and we follow through the implementation by either your quality team, the leaders from the facility, and we offer the mentorship and guidance throughout the year. But above that, we offer the certification according to the level of quality achieved. So tools, we have tools that we use. They are digital tools. These are quality platform tools that will enroll the facilities, and that facility owner and leaders can see the changes that his or her staff is doing, but the staff also what is doing, and for us, you can follow through whatever is going on. This offers the customized plan according to the gaps that you have found. There are different priorities that you need to do according to your facility, and for us, we'll be there to expert mentorship throughout the year to make sure that you move from the certain level of quality to the above level to the quality and even higher level that you can maintain, preparing you even for accreditation. So how to enroll? I am here with my team. Contact us today. We shall come to your facility and make sure that we enroll your facility into this program. We shall come and do the assessment. After giving you that assessment and finding the gaps that are found in quality, we shall give you the quality improvement plan. After that, we shall follow through progress that you are doing throughout the year and making sure that the gaps that are found are closed. But we shall also give you certificate and celebrate every level of quality improvement that you are gaining. So feel free to reach to me. I'm here. But I also have my boss, Dr. Omar Chiro. If you found it and so forth, you can contact me. We shall be here all and let us talk about it. These are some of the people that we did our assessment so far. And I welcome even other facilities, both government and private. Please let us enroll into this program because quality is the way to go. So you know what? Quality is the way to go. And now the question is no longer about how much you can invest or whether we are ready to invest into it. The question is it, can we afford, like, are we afford quality? How we afford not to employ quality in our facilities? I welcome you so much. Let us connect, let us do this to ensure that not only accessible, but at the highest quality of healthcare delivery. Thank you so much. I'm happy to be here.
Thank you so much, Dr. Arnold. And this is echoing the previous presentation from Dr. Ntuli on investing on the youth. Can you give a round of applause to Dr. Chilo on investing on the youth? We've had a very nice presentation. Thank you. And again, in that line, the next speaker is Dr. Neema Mrimi, which is also going to also reflect in the past presentation of Dr. Ntuli, again, investing in the youth. At MAT, we are planning to pioneer a junior doctor chapter in a way to link from when medical students graduate and link them to, the senior colleagues and senior professions. We're thinking that this is a way to go. So Dr. Neema Mrimi is our pioneer of the junior medical doctor, and she's going to take us through on what are the works that have been going on in the next 10 minutes. Neema Mrimi.
Good afternoon to everyone, and please welcome to this talk. I'm Dr. Neema Jeremiah Mrimi, and I'll be guiding you through the introduction to Junior Doctors Network. So, while we are waiting for a slide, I need to remind you one quote, which normally say, if not us, who then? And if not now, when then? It is now or never. I just want that every junior doctor, every youth in this room to think that he or she has obligation to be part of the youth wing of the Medical Association of Junior Doctors Network under the umbrella of MAT. Can I see the waving of the hands of the junior doctors or the young profession? Raise your hand. Can you wave? Thank you. Please follow. I think we'll be together on this, and I need you people to feel energized because this is really a movement. Next time we don't want to see these blank seats in the room, so we want it to be full. So I'll continue because I see the slide is just getting late. So every year, Tanzania produce and train more than 1,000 doctors. But more than a half, which is 50 to 56%, leave the system. And that is not just a number. It is our future walking away. And to me, it feels like lecturing in an empty hall and later keep listening to the echo waves coming back to you. So we need to change that narrative. The attrition rate show that the number of doctors which are quitting from medical industry is increasing gradually from 2009 to 2025. It keeps increasing. And that is not a good sign. It is alarming that Tanzania, in the future, it will face doctors' workforce challenge, regardless of producing huge number of doctors, which it cannot even consume them. It is also a wastage to the government budget, as the country wastes up to $25 million annually, equivalent to Tanzanian shilling 65 billion. This is according to Seal et al. 2013. And this silent crisis, it requires rapid reforms in human resource management and a long-term planning to protect public investment and to maintain the future workforce in the healthcare system. The junior doctors are the workforce to the healthcare system. If we want to protect them now, in the future we're going to face the challenges in workforce. So, junior doctors in this room, close your eyes, take a deep breath, and then release. I want you to think outside the box and try to think of a classmate you studied with for the 5 or 6 years, someone who sat next to you during anatomy classes, pulled all the nights before exams, shared the dreams of saving lives with you. Now imagine the same friend, the same doctor you studied with, who was very passionate, capable of leaving the medical profession, not because they wanted to leave, but because, and even not because they choose to leave. It is not their choice they made, but it is because of the circumstances, which is very unbearable, unemployment, burnout, lack of mentorship, or even migration pressure, forced them to quit from medical industry. And this is not just one story. It is a story of far too many junior doctors in our country, and some of them are even in this room. And that is why we are here today, to make a change, to make the voice to be heard, to give our stories, our voices out to the seniors who are in this room, to the people, to the policymakers, that they can hear our voices and empower us. Please, can't you clap for this? Today, we will be relaunching a network that does not just connect us, but protect us, support us, and empower us. Now, who is a junior doctor? I understand many people are against this word. When they hear junior doctors, they think maybe he's a teenager or something. No. According to the World Medical Association, it defines as a doctor within 10 years of their medical graduation, or who are still in an ongoing postgraduate medical education. Can you play the video? So, from the definition of junior doctors, the World Medical Association launched the youth wing inside the World Medical Association, and it was launched in Vancouver, Canada, in 2010.
The Junior Doctors Network serves as an international platform for junior doctors to facilitate an open dialogue of global events and activities that are relevant to their postgraduate training and the World Medical Association. It was founded in the 61st World Medical Association General Assembly in 2010 October in Vancouver, Canada. The purpose of the Junior Doctors Network to empower young physicians to work together towards a healthy world through advocacy, education, and international collaboration.
Thank you. So the Junior Doctors Network is just not only the national platform, it is international platform. We want to see junior doctors collaborate at international level, cross borders. Look, I want to see junior doctors at the top. So also the Commonwealth countries adapted this network in 2024 after the United Nations Development Program, the UNDP, give out the result of population projection. So the Commonwealth countries adapted this Junior Doctors Network and declare the declaration to empower junior doctors. Can you play the video, please?
The Junior Doctors Network serves as an international platform for junior doctors to facilitate and
So that was happening in 2024. Thank you. Can we go back to the slide? So, based on that population projection, also Tanzania was among the countries with the highest population growth. Approximately by 2050, Tanzania will be having more than 140 million people. And during the presentation of census in October 2022, President Samia, when he was giving out the result, she stated that such population must be a burden for a huge country like ours, but it's a burden when it comes to allocating resources and delivering social services. We need to start preparing development projects for these people and making necessary reforms in our policies. So, when we are talking about delivering social services, are the health services not a social service? Doctors, I'm asking, are the health services not social services? So, if we are not making sure that we prepare for this, we are going to be left out. Now comes a call for the action. In order to counteract that projection, and if we truly want to strengthen the primary health care in Tanzania to align with population growth, we must invest in the backbone of the health centers. And which are the junior doctors who deliver services from dispensary health centers, district hospital, regional hospital, zonal hospital, up to the highest level of the national hospitals. Empowering junior doctors means building a stronger, more accessible, and more equitable health system for all, and where it comes the universal health coverage. If we want to invest in junior doctors who are the backbone of the health system, what are we expecting in the future of our healthcare system? And how are we empowering the junior doctors? We are empowering the junior doctors by addressing the challenges faced by junior doctors. I know junior doctors, they'll get a chance to present their challenges, but I just highlighted few of them. So, most of the junior doctors today face stress and mental health neglect, underemployment and unemployment, lack of leadership skills and management, limited career growth, lack of mentorship and capacity building, ethics misconduct, attrition and dropouts, poor digital health innovation, lack of interest in participation in medical association, for example, the Medical Association of Tanzania, lack of exposure to global community, for example, the limited access to international research, and also networking platform regardless of increasing the use of social media. Lack of presentation in policies and also limited awareness of rights and safety protocols. We are the future of the health system and digital health innovators. We are requesting, please empower us. Thank you. God bless Tanzania, God bless Africa.
Hayo makofi hayatoshi jamani kwa Neema. Can we give her the applause she deserves? Neema, before you leave, Neema, as Tusharama Hussein prepares to come to the podium, I think this presentation deserves at least one comment from a senior colleague to encourage these doctors based on the challenges that have been announced. If any senior colleague
wa kwanza ni mwalimu wetu wa siku nyingi tuliyemtambulisha asubuhi ya leo, naye si mwingine ni Dr. Marina Njelekela, kwa sifa zake zote na alivyo navigate through the profession, na kwa kuwa ni mwanamke anaweza akasema vizuri kumtia moyo mada. Makofi mnaponiunga mkono.
Makofi, makofi, makofi wakati anakuja mbele. Aje mbele kabisa.
Thank you.
Makofi, makofi, tumsindikize Dr. Marina.
Yeah. Wakati anakuja nilipoombwa kwamba tuingize mada hii kwenye ratiba siku 6 kuwapa nafasi madaktari vijana kuonyesha talanta zao za uongozi na ushiriki katika sekta ya afya. Sababu zilizoniongoza ni kwamba bara letu na nchi yetu average age ya Mtanzania ni miaka 17. Kwa hiyo huwezi cooperate kama vijana wa taasisi yote, huwezi cooperate kama huwezi kuaccommodate vijana wa miaka 20 ambao tayari wamesha machua na wana degree na wako mtaani. Asante sana kwa kuratibu hili. Karibu senior wetu, tunajivunia kuwa nawe.
Asante. It's a pleasure to be here, na nimefurahi sana toka jana kukutana na wanafunzi wengi ambao walikuwa mpaka wanakumbusha pyramid tract. So thank you very much for the presentation and us to challenge as senior medical doctors. How do we embrace the young of doctors who are coming into our profession every year? For me, what I would like to urge for the young is to find mentors, have mentors across the board. When you are in the medical school, when you are doing those research and the like, you are pinned to seniors, isn't it, to the department. But increase the scope. Find any mentor from any discipline at the school. But when you just get into the profession, you finish your internship and you start working, wherever you are posted, quickly look for mentor. Look for a mentor wherever you're working. And for the Medical Association of Tanzania, we can design a mentorship program whereby we are paired with junior doctors as they go into the profession. Because seriously, we face a lot of challenge. I can even give my own example. When I just completed my PhD, what to do. And if it was not for the late Association of Tanzania, for the Medical Women Association of Tanzania, we need to have organized mentorship program so that we engage young doctors as they just from the university, they go through internship, we get them on board. Because it's not easy to go out there and start by yourself. You will rotate, you will run around and the like. So for example, for me, with the Medical Women Association, for those who are in the association, I'm called super mentor because everybody so get to join the Female Medical Association. You have joined already. So she has already. So in there we are senior. We keep encouraging young doctors, female doctors, but we can go broader with the Medical Women Association, pairing with the Medical Tanzania. We design a mentorship program for our junior doctors. They really need our experience. So, and wherever you are working as a senior doctor, I urge you, pick 1 or 2 young doctors who are joining your hospital and mentor them. That's it, because they are there with you at that facility. They have nowhere else to go. So each of us, leaders, old generation, mentor young ones, and some of these challenges, they will go away from them.
Thank you for both of them. Very insightful, and maths tumelichukua na tutaenda kulifanyia kazi. Next is going to be Tusharama, to give an oral presentation of a research titled Dropout Rates and Factors Contributing to Adherence Among Adult Heroin Addicts Undergoing Methadone-Assisted Treatment at Sekoture Regional Referral Hospital. Karibu.
Thank you. Good afternoon, everyone. My name is Tusharahma Hussein Tuli. I'm a medical student from Bugando, a Catholic University of Health and Allied Sciences, KUHAS. Okay, so I'll be taking you through our research presentation by the title, Assessment of Dropout Rates and Factors Contributing to Adherence Among Adult Heroin Addicts Undergoing Methadone-Assisted Treatment at Sekoture Regional Referral Hospital in Mwanza, Tanzania. So I did this with my fellow colleagues as well as supervisors that were Mr. Peter Chilipweli and Dr. Hauli Kieti, who is also a psychiatrist. So these are the outlines: the introduction, objectives, methodology, results, discussion, conclusion, as well as recommendation and acknowledgement. Yeah, so I'll begin with the introduction. So opioid. So, with introduction, opioid is the second most abused psychoactive drug in the world after cannabis. According to the World Drug Report in 2023, 296 million people were using drugs. By 2021, that's a 3% increase over the past 10 years, according to the research, and 25% is women. So methadone-assisted treatment or medication-assisted treatment, the words can be used interchangeably, for opioid addiction, in short MAT, has been effective in facilitating recovery from addiction to many patients. However, some studies do show that not all enrolled clients do adhere to medications till they graduate or they finish their dose. So a study done at Kenya, at Madaktari National Hospital, MAT Clinic, this study showed that the heroin abstinence rate among the enrolled patients, where the majority of the patients were said to continue using heroin even though they were still in the methadone clinic treatment. So this study was done by SQF 2021. However, that was done in Tanzania, here in Zanzibar, by Bakari AM. So in 2021 also, it assessed the relapse from those that were taking the clinic, those that were using methadone treatment after rehabilitation. Yeah, so the aim of this study was to fill the gap between the dropout rate and factors that contributed to adherent heroin addicts undergoing MAT who are secure. So this was because everybody from the treatment, but some retained. So we had to know why these retained and why others left. So the objective of the study the broad objective was to assess the dropout rate and factors contributing to adherence among heroin addicts undergoing assisted treatment at Seketure Regional Referral Hospital Methadone Clinic. And the specific objectives were to determine the dropout rate in addicts undergoing medication-assisted treatment at Seketure Regional Referral Hospital Methadone Clinic, and the second specific objective was to determine the factors for adherence to the medication-assisted treatment at the same clinic. So the methodology used, the study area and duration was Seketure Regional Referral Hospital Clinic, and the study was done from October to December in 2024. The study design was a prospective cohort study that was conducted for patients that enrolled between the February 2018, where this clinic was started, till March 2024. So, and also a cross-sectional was conducted in October to December for as they were ongoing events. So the study population was a sample of 203 adult patients that were consented to participate in the study, and the sample analysis and data management was collected using a structured question, processed using the microscope Excel, and analyzed by IBM SPSS version of 25, as well as the ethical clearance was sought out in Mkuu and Bugando Research Ethical Committee. So among the this is a participant tree, so it just gives out how all in 121 clients that were recruited from February 2018, when the MAT clinic at Seketure was started, until the time that was being done. So until the time the research was being done, that was October 2018, that are there the clinic were only 311. So this gave out a dropout of clients that were 510, giving out then the sample taken from the 311 was 223, leaving behind the 80. So this was a simple sampling method that was used. So among the results, so the things that were comparable, in the demographics of the dropout clients that were no longer in the hospital, that means the information was taken from the hospital gallery, I mean the files and stuff of the patients that were no longer there. So a simple number of 153 clients were included in this, with those that were no longer at the clinic. So in the terms of gender, in male clients were a larger percentage of a dropout rate, that they were no longer in treatment, with a leading of 97.4%. With the education levels, it was more to those that were having primary education level that were dropping out more in comparable to the other educational levels, as well as those that were single were seen to be dropping out more from the clinic treatment. With the comparison between those that dropped out and the clients that were adhering to the medication, the male 97.5%, with those that are there dropped out. It was significant, more significant, and in the age group it was more significant with the age group of 18 to 25, whereby those that are there were in 24.2%, and those that dropped out was 21.7%, as well as the age group of 46 to 55, whereby those that are there were 24.2%, and those that left treatment was 21.4%. So in the education level, as I said previously, with the dropped, it was primary education level that were leading. So it's also the same with those that also adhered, followed by the secondary and the higher levels. And with employment status, it seems those that were unemployed were more in both adhering and dropping out. So with more significant in those that were dropping out, there were more of unemployed clients. So I'll proceed with the discussion. So the study revealed a significant dropout rate of 37.9% among the heroin addicts undergoing the methadone-assisted treatment at Secretariat Regional Referral Hospital, with males, as we saw, disproportionately representing among those discontinuing with the care trending, and it consisted with a global observation linking male gender being higher, with a higher dropout rate due to the factors that we saw. So more or less stigma and other impulsivity also showed that there would be other causes for these males to be dropping out. So this aligns with Tanzania studies that were also done. In MAT dropout rates of 30% and 40% was seen in a study done by Bakari AM and also Ardena at 2010. And also most dropouts were males, with 97.4% in that study, and had only primary education levels. So this supports this supports also the low education levels indicates a risk for factor treatment discontinuation. So in conclusion and recommendation from this study, the dropout rate was significantly influenced by gender, education level, and social support and treatment environment. So to improve this, we have to improve the adherence by tailoring probably the environment that these people are getting the treatment, and also we should focus in supporting the male clients, especially those with low education, and also by strengthening the social and psychological support and creating a more private and welcoming environment for them to either come and not being associated with their society just because they are using the MAT clinic. So further research is also needed. However, I thought because in Tanzania we only have few methadone treatment centers. I say few because of the population that we have and the number that we have. I believe it's still less than 10 in the whole of Tanzania. So I believe increase in methadone centers in the country currently would help also in reviewing this, and also increasing a number of sober houses whereby these people can go and be able to be treated and with no stigma. And also it's important for to offer a means of these people to be able to be employed, because not many employers trust those that were previously using heroin or those that were previously known as addicts in the society for them to be employed. So I think maybe in these centers that we give out the methadone treatment, also maybe vocational trainings or some education could be provided that these people can be also able to employ themselves. Yeah, thank you so much for this opportunity, and thank you everyone for listening.
Thank you so much for that insightful presentation. So we were supposed to have 5 minutes for questions for the previous presenters, but because of expression of interest to the presenters that spoke before tea break, we are also going to allow questions to those presenters. Are there any other burning questions to the presenters that presented before tea break? From the Ministry of Health, from the NHIF, from NIMRI? Bado tuna maswali ya kuwauliza. Hebu nione mikono, ili tujue kama tunafungua ama hatufungui. Mikono. Okay, so we're going to take hiyo mikono. Msishushe sasa ili niwamaki. Hiyo mikono iliyonyooshwa.